Welcome to CancerSpeak, the official podcast for Cancer, a journal of the American Cancer Society. I'm Dr. Suresh Ramalingam, Editor-in-Chief of Cancer and host of today's episode. I'm also a thoracic medical oncologist and serve as the Executive Director of Winship Cancer Institute of Emory University in Atlanta, Georgia. Today, I'm thrilled to be joined by Dr. Serban Negoita and Dr. Ahmedin Jemal to talk about Part 2 of the annual report to the nation on the status of cancer, which is the largest study to date using population-based registries to assess the impact of COVID-19 pandemic on new cancer diagnoses in the United States. Dr. Negoita and Dr. Jemal, thank you for joining us today at CancerSpeak.
Thank you for having me today. I'm Serban Negoita, a cancer epidemiologist and public health physician by training. Currently, I serve as a branch chief for data quality, analysis, and interpretation with a surveillance research program at the National Cancer Institute. We are best known for our surveillance epidemiology and end results program, best known as a SEER program.
Thank you, Dr. Ram. My name is Ahmedin. I lead the Surveillance and Health Equity Science Department here at American Cancer Society.
Thank you so much for both. Ahmedin, I can't resist the temptation of leading off with a question to you, given all the phenomenal work you've done in helping us understand the epidemiology of cancer in the country and in the world. Where do we stand as a nation in our fight against cancer?
I think we are making progress in reducing mortality from cancer. Since in 1990, when cancer rates peaked in the U.S., rates have decreased by over 30%, about 33%. And this decline is largely driven by reduction in smoking prevalence, improvement in early detection and treatment. We are making progress, but there is a lot to go because still there are about over 600,000 people dying from cancer in the U.S., and at least 40% of these cancer diseases could be prevented by applying what we know in cancer prevention and control. There is also, of course, areas for new discovery from prevention to early detection and treatment.
Thank you. Indeed, there is still a major need for upping our game to save more lives. Serban, let me turn to you and ask you to provide us with a summary of the main findings of the annual report to the nation on the status of cancer, Part 2, that was just published in Cancer a couple of weeks ago.
Sure. For this investigation, we analyzed the patterns of newly diagnosed cancer cases for years 2015 to 2020 using data reported to the North American Association of Central Cancer Registries by 17 population-based registries that cover roughly about 1/4 of the U.S. population. So that's really a large population base. And we compare the number of newly diagnosed cancer cases in 2020 to what was expected based on the previous 5 years between 2015 and 2019. And we look at 4 major cancer types that are diagnosed through screening tests or other forms of early detections that might have been disrupted by the pandemic. Specifically, we look at female breast cancer, lung, colorectal, and prostate cancer. And in addition to this, we selected thyroid cancer, which is often diagnosed incidentally during routine procedures. And we also look at pancreatic cancer because pancreatic cancer is usually diagnosed because of symptoms. So in addition to looking at the number of newly diagnosed cancer cases reported to registry, we also look at the volume of electronic pathology reports transmitted to the registry. And we did so because pathology reports are transmitted in real time, and therefore they are less prone to be affected by operational delays in reporting. In other words, we use pathology reports to validate our findings based on the number of newly diagnosed cancer cases reported to registry. And we found that the new diagnosis of these 6 major cancer types, all of them fell abruptly in early 2020, coinciding basically with the start of the COVID-19 pandemic. The pathology reports also declined sharply in the same period, and this suggests that fewer cancer screenings have been conducted, and in general, there were fewer cancer-related procedures, maybe fewer cancer-related surgery conducted during the same period. So we found that the decline was more pronounced among cancers that have an early detection program, such as breast cancer, for example, and it was less pronounced among cancers that are diagnosed based on symptoms, such as pancreatic cancer. We also found that the magnitude of the decline varies with demographic factors such as age and race. And if you take all these things together, basically the conclusion is that many cancers have most likely not been diagnosed in a timely manner during that early months of COVID-19 pandemic, and that is possibly related to the interruptions in medical care that we experienced in that period.
Wow, thank you so much. So that leads me to the next question. What does that mean for what trends we're likely to see from 2021, 2022, and 2023 in terms of cancer diagnosis? I know this work did not include that, but just if you can talk us through your thoughts on that.
I think that this is one major area of continuous interest for us to understand first whether indeed we are going to see an increase in the number of cancer cases diagnosed at late stage, cancers that were not detected earlier through the screening procedure. So that one very interesting question that probably will be able to answer in the next year or two. And then someone would expect that these cancers that were not diagnosed early enough, they will be more likely to experience a recurrence or to experience a shorter survival, and therefore after a number of years we might see an increase in mortality. It is difficult to predict whether indeed there will be a peak in mortality in upcoming years, and it's difficult to say whether this will happen 2 to 3 years from now, or maybe we'll have to wait 5 more years of follow-up, but this is definitely something of high interest for the National Cancer Institute.
Thank you, Serban. When I read the paper, I also saw that you report that the reduction in diagnosis of these cancers was not uniform across various subsets of patients. So there were some disparities there as well. I was wondering if you could elaborate a little bit on that.
Of course. So, for example, what we've seen is that Asian and Pacific Islanders population had a greater decline in the new cases for all cancer types except for pancreatic cancer when compared with whites or blacks or American Indians and the Alaskan Native population. We knew that there are various financial, linguistic, and cultural barriers that prevented Asian immigrants from using healthcare services even before pandemic. Generally, the screening penetration among Asian population was lower than among whites, for example, before the pandemic. And probably during the pandemic, the magnitude of this deficit was increased, and probably that's why we've seen this even greater decline among Asian and Pacific Islanders. And we also seen some notable differences, for example, with respect to prostate cancer. The decline of prostate cancer was higher among whites than among blacks. It is well known that blacks are at a higher risk for incidence and for mortality from prostate cancer. So to some extent that was an unexpected result, but maybe this result reflects the fact that black men are aware about their increased risk of developing prostate cancer. So probably they were possibly more prone to go and seek medical care, maybe more than their white counterparts. And I have to say that for other types of cancer, for for example, for thyroid cancer, the decline in the number of diagnosed cases was significantly higher among Blacks. And keep in mind, these are the cancers that are diagnosed during routine medical encounters. So probably overall, this higher decline for thyroid cancer among Black population reflects maybe even a higher deficit of medical encounters among this segment of the population during the first few months of pandemic.
Thank you. So it's clear that we not only have to get people back to screening, but we have to target our efforts to various groups based on your findings. So I have one last question, which is to ask Ahmedin to comment on what the American Cancer Society is doing to get people back to screening. And Serban, if you can comment on what the NCI is doing, that would be informative for our audience. Ahmedin?
First, I would like to chime in on what Dr. Negoita already talked about, the difference in reduction in the incidence rates or in case counters. Asian Americans had the largest decline or fewer cases because that really is consistent with the screening uptake. Screening uptake was during COVID. The reduction in the screening uptake was the highest in Asian American. I think it's for many reasons. One would be really there was an increased violence against Asian Americans during COVID related to what we know of the source of COVID infection. Second, you have also language barriers might be also a factor. And also some studies actually show that Asian Americans were more likely to stay away from COVID infection. Actually, mortality rate is the lowest in Asian America. So going back to what SS is doing to increase screening uptake, SS is taking a very comprehensive approach. First, it has convinced national experts to identify strategies to increase screening uptake. We have also a similar approach to increase screening by working with state officials and state departments. Third, American Cancer Society works closely with health systems. For example, in 2022, American Cancer Society has led over 114 interventions, over 721 clinics throughout the U.S. And this has led to over 360,000 screening and to over 7,000 new diagnoses of cancer. The last approach that SS is doing is I Love You to Screening campaign, which provides a quick facts about cancer screening that patients can take to their doctors. SS also developed a tool to locate screening areas at a zip code level. There is a website that listeners can use to find out where to find screening areas for each of the cancer sites. getscreened.cancer.org.
Wonderful. Serban, what's the NCI doing?
I already mentioned our interest in continue to track the incidence of cancer and understand what will be the effects of this interruption in screening that Ahmedin discussed previously, and also to understand whether we are making a good progress increasing the penetrance of screening among different population groups. And of course, the Institute continues to work towards the goal of cutting cancer mortality rate by 50% in 25 years. It's an ambitious goal, but it's a realistic goal. And we believe that the research that takes place in our agency helps to meet this goal. Our focus obviously is on cancer research, prevention, and control among all communities in order to accelerate the rate of decline in cancer mortality. And we believe that obtaining a decline of about 4% per year in cancer mortality will put us on the path toward achieving this very ambitious goal of cutting cancer mortality rate by 50% in 25 years. So again, research to promote prevention and control of cancer in community, it's what our institute and our group will focus to alleviate the effects of the COVID-19 pandemic on cancer patients.
Thank you. It's obvious that many organizations led by the NCI and the American Cancer Society are doing a lot to bring people back into screening with the overarching goal of reducing the burden of cancer. This has been a very stimulating conversation. That's all the time we have for this episode of CancerSpeak. I want to thank Dr. Jemal and Dr. Negoita for their valuable work that was just published in Cancer, and they're taking time out of their busy schedules to join us today. Also want to thank our listeners who tuned into this episode. I encourage you all to read the Annual Report to the Nation Part 2, which is now available as an open access article in Cancer. And of course, we will include a link to the report in the notes for this program. Thank you once again for joining us.